Okay, 7 o'clock Eastern Time. Welcome. My name is Mike Amendola. I am a professor of surgery at Virginia Commonwealth University. I'm going to be talking tonight on the mastering the third year clerkship, partial strategies for success. And we'll just get started. And I'll get through the slides pretty quickly, and then I'll open up for questions, any feedback you guys have. There's a discernment tool at the end that might be helpful to you if you're in your early clinical years. This is just disclosure, say that I'm not representing any views of the United States government. I am the founder of Amendola Surgical Intelligence, which is an AI-based company I use to help medical students and residents in terms of discernment and also help them in terms of match success and ultimate mentoring. And then I'm the creator and investment of Vulcan, which is a tool that I've used and developed based on some 25 years of literature to help medical students in terms of them understanding if they really want to think about maybe potentially doing surgery as a career. So I'm going to talk about the history of surgical training. I'm going to talk about the training, the learning transition. What's a clerkship? You commonly hear that in the halls of the hospital and medical education. What are typical rotations, tip for success? And then I'm going to show you guys links to the Vulcan tool, and I encourage you to take advantage of it. It's a free tool that I've published, and it's readily available online and help you understand potentially discernment toward surgery as a career. So what's the history of surgical training? We started with an apprenticeship in surgical training. This is a picture from Hopkins. This is where the term rounds actually comes from. This is the dome of Hopkins. So the patients were in rooms around the dome, and you went around the dome to check on the patient. So that's where the term rounds comes from. So basically, apprenticeship model is you're training with someone. There's power structures within surgery, especially if you're training in an apprenticeship model, and a lot of hidden outcomes and challenges within surgery. Halstead came through in the United States, and then he started with dedicated apprenticeships, particularly at Hopkins was the first kind of surgical residency in the United States. And not all learners advanced at the same time, and it was a very competitive system where people were eliminated from surgical training as they went through. It's also known as the pyramid system. So you start with more people at the beginning, and at the end, whoever was left at the top of the pyramid were the ones that completed surgical training. It's not uniform in its presentation of disease, so you might not have seen everything, but you're trying to survive till you get to the end. The system as we know it now in the United States is based on the money that Congress gives through Medicare funds to individual hospitals to support training of surgical residents, and ergo subsequently second order down to medical students. That system is balanced. It was balanced in 1997 by Clinton. This is a picture of him signing the Balanced Budget Act 1997. And basically at that time, they froze all resident positions. There were no additional positions that were available. So now in the 80-hour work week or the modern era of surgical training, additional positions, if you want them, have to come from the hospital. Residents on average work 80 hours a week. That leads to quote unquote reduced errors, but also potentially it's to protect the learners at the resident level as they train in surgery. Just as a point of reference, I put on here July effect. We are in July. This is the beginning of the academic year, and commonly people say, is there worse outcomes in July? It turns out that that's actually not true. But this has kind of led to what I call the prison model or the time served model. What you see is what you get during the time period. So you go into a residency, you're there for 4 or 5 years as a general surgery resident, and then you come out. Now, well, the issue is that this is changing over time, what we call the milestone. The extension of medical students, what they call the EPA or entrustable professional activities. I'm not going to get into that tonight, but that's an ongoing issue with medical education. For the modern medical school, that started basically in 1910. This is a famous paper you can get online. This is called the Flexner Report. And basically, prior to the publishing of this in 1910, medical schools were basically you pay for it, you get the education, you get the degree, you paid for individual lectures. So this was revised to formal medical schools, and basically it broke down and recommended there be a basic science curriculum and early medical school education, and then subsequent clinical rotations or clerkships that students were able to experience. In 1942, FDR signed the LCME basically, well, he signed the Selective Service Law, which basically said you have to have dedicated curricula, and that has to be approved by medical schools. So that was the standard for medical schools. That's where surgical rotations actually came from. The modern medical school surgical rotations have what we call required clinical experiences, or RCEs. These are known to most all medical students, which is medicine, psychiatry, surgery, OBGYN, pediatrics, and family. The clinical settings are outpatient and inpatient, and alternative activities can be sought and granted to medical schools, but they have to petition for that for medical students to get that. So what does that really mean when you transition into these rotations or these clerkships? So right now in kind of early medical school years, you're basically a passive learner. People are lecturing to you, you're listening. Commonly you're listening in your bed, sometimes you're listening in your house, maybe with your cat in front of a fire, but you are listening to the information. They show you stuff, you write a lot of that down, you capture that, you process that stuff, and you give it back to them. And then anatomy is a classic example. This is a historical picture from an anatomical dissection. But during that time, you get kind of an outside view of the hospital, meaning the hospital looks very, very ordered. Everybody gets better. It's an ordered place. Medicine has progress. We're all going toward the truth, and it's what's ultimately in the best interest of the patients. The clinical world, in contrast, during your third and fourth year, in particular during the clerkship, is an active learning environment. They speak, you listen, but you listen and they speak. So you go back and forth. It's an equilibrium between you, the patients, and the residents for you to get exposure, clinical exposure, what's going on in surgery. Both you write and process what's going on with the patient and the patient information as it happens. The clinical world also, both get feedback. You're swimming in a clinical environment. Sometimes you sink in that environment. If that's the case and you get into a situation on your clerkship where you feel like you're overwhelmed, you need to ask for help. And there are definitely, in all medical schools in the United States, there is curricula, or there's clerkship directors and clerkship aides that can help you, but also the medical school has a lot of different avenues for that as well. Remember, it's a back and forth with your teachers, other learners, residents, and patients, and attendings as well, in the midst of all of this. But a lot of times you're learning in the midst of residents learning as well. So there's a fair amount of ongoing stuff in the environment, and can be kind of dynamic when you're there as a medical student. But inside, this is where you get the kind of the view of the inside of the hospital, which sometimes, as you can tell from this trash can, it's ordered at times. Everyone seems to have a place in it. Sometimes, except for me as a medical student, I feel like I'm a bother. Sometimes I hear students tell me that. And would they even miss me if I didn't even show up? So, I think a lot of times you have to advocate for yourself in this environment. Remember, the bottom line is you're paying to be there. The residents are paid to take care of the patients and learn and train in surgery. So it's a little bit different environment for you as a learner. The inside view of the hospital also, medicine is really ordered. It's not really ordered. There's a fair amount of disorder. And toward the truth is a lot of times a point of view. Everyone, quote, acts in the best interest of the patient. That sometimes you will find is not necessarily true. And it can be confusing which way is the right way. So as a student, it's not uncommon for you to kind of feel like you're kind of trying to figure out which direction I want to go with the patients. Remember, for socialization, most example or definition of socialization, the process of inheriting norms, customs, ideology, and maybe provide the individual with skills, habits necessary for participating within their own society. A society itself is formed through a plurality of shared norms, customs, values, traditions, special roles, symbols, and languages. So when you redo this for the medical school, or for the medical student, it's the process of inheriting norms, customs, and ideologies for an individual medical student with the skills, habits necessary in participating in their own specialty. And a specialty itself is formed through a plurality of shared norms, customs, values, traditions, and special roles, symbols, and language. So the customs and ideologies are kind of the agreed or stipulated aspects of what we say when we say how we say it when we're looking at disease with a lot of patients. There's a fair amount of variety and variation in customs from hospital to hospital, provider to provider. And sometimes that makes it hard to learn within this environment. But remember, all specialties kind of share a general approach to patients and disease. And that's really what you're trying to get to the root of when you're in the surgical rotation. So what is a clerkship? So per Webster, a clerk is an administrative worker that's responsible for keeping records, managing accounts, or performing general office duties. And then why do you have clerks? Why do we have clerks in this environment? We have clerks because there's a lot of different information streams. We have to keep up with patients and the residents and other services, and we have to care for patients on a daily basis. And then clinically figure out, okay, what do they need and what are those needs and how are they changing throughout the day and throughout their hospitalization. But as a medical student, you remember you're trying to ideally barter for teaching. In ideal world, everyone would enjoy teaching, and that's not necessarily the case when you're in clinical rotation. Reality is people in medicine and in residency, quite frankly, have a variety of reasons for being there, learning itself, and most residents don't see themselves as teachers, even though the majority of the education you'll get will be from residents. But be smart about your role. Remember that you're kind of bartering your time and efforts to help take care of the patients, help the resident, but ultimately learn from the resident as well. So typical rotations, when you look at rotations, this is kind of what most breakdowns, this is our medical school, how we break it down. We have 2 specialty weeks, 2 weeks each, and then we have a core rotation in surgery and then the subsequently shelf exam. The specialties can be any one of these things: urology, vascular, CT, ENT, plastics, peds, ortho, transplant. And then usually the 4 weeks of the core rotation is general. And then you can have those swapped. So sometimes you'll do your core month first and then your 2 weeks afterwards. For the shelf exam, and I get asked a lot of times, this is again the final exam, if you will, in surgery. It's mostly a medicine shelf for surgery. I tell residents or medical students that all the time. You want to read for the shelf. Dr. Pastana's Surgery Notes is an excellent book. My suggestion to you is get it and make your notes in there as you go through your rotation. Surgical recall is something that you read for the rotation itself. And that's pretty helpful for you to figure out, okay, hey, this is what I'm going to be asked when I get in there to do this particular case. These are the most common questions that I'll get questioned when I'm doing this case. So this is kind of a typical day. So most students in our institution will sometimes show up sometime between 5 to 6. They will see patients. They will round on the patients, obtain information, and then they'll do work rounds with the residents in their individual wards. What are work rounds? Work rounds are usually with the residents. Usually you're presenting to the team. There is some teaching during that, but this is really the day-to-day work of taking care of the patient. It's looking at wounds, checking vital signs, looking up labs, physical exam, reinforcing exam, what happened overnight. Those kind of things are coming up on work rounds. So, again, so student notes, and I put this on here. So student notes, a lot of it depends on what your local rules are, based on what your exam is, the correct assessment, the corrected plan, and usually in a SOAP format. What is SOAP? SOAP is subjective, objective, assessment, and plan. You've probably been exposed to this, but I'll briefly go through it. Subjective is your opening. What's your general salutation, the name of the patient with the diagnosis, the age of the patient, post-operative day, and hospital day. The subjectives, what's happened in the last 24 hours, operation, consults, change in stability, new complaints, cause and effect in the previous plan. Pro tip is ask the nurse. Usually you're in the hospital very early. The night nurse is usually still there. Ask them how it went overnight. Was there any major issues or anything you want the nurse for you to bring up with the team? That's a nice way of asking them, hey, is there something that you want to advocate for the patient? And oh yeah, by the way, I will help you do that. You'd be surprised how much information you can get from nurses when you just ask them that way. The objective is what's going on with the vital signs. You're looking for ranges, highs and lows. Labs, what happened in the last 24 hours. Any radiology, so chest x-ray in the morning. Was there CT overnight? And then the exam. What's your focus exam? How does it change? What is new? What is different? Is there something new? Is there a new finding? So you maybe find something on rounds on when you look at your patient. Then you reinforce that with a resident. The resident goes in and says, you're absolutely right. Now we got to write up a quadrant tenderness. Maybe we got an acute cholecystitis on our hands. So those kind of things happen, and you got to definitely go through the dynamic. Assessment, you want to reassess, kind of restate what the critical points were. Final clinical exam based on your representation, the objective data, confirm the diagnosis, question your diagnosis. And you know what? You might run in the morning and say, I don't know what the diagnosis is. I don't know what I'm looking at here. And you get that feedback from residents. So residents are more likely to give you that information. The plan. So that's kind of the advanced knowledge and integration piece. And when you're looking at patients in the morning, it's what you plan to do based on your assessment. You might get it wrong, but my advice to you is take a stab at it and try to figure out what you think. Even if it's completely off base, at least you're making an effort to try to pull things together clinically. So, and this is kind of the day to day. So now, once you do those rounds, then you during the day, you're either going off to the operating room, or you're going to the clinic, or you're in the hospital seeing consults, or you're in the ED covering traumas, for example. You might even break and go to lectures or rounds. So there's a variety of different things, but that core morning thing is kind of how you start your day. When you're on call, and I put this kind of in quotes because I know every medical school has a different policy. It's school to school. It's embedded usually with resident teams. Sometimes you're in a place like you're based in the ER for 24 hour for 12 hours or 8 hours, and possibly you can be assigned to your service to cover your own patients. But a lot of times you can pick up cases overnight and see different things and and interface with different things. So, what are some tips for success here? No matter what, your education is couched inside of the overall environment of surgical education. The language you use in here is what you need to interpret for your patients. Knowing the geography will help you kind of figure out what the clinical practice is. Remember also that these student notes in the morning, you want to try to write them before rounds. So, you want to try to pre write your notes and then complete them after you've completed rounds. Because literally, if you can pre-op and pre-write your note, put your labs in, then round with the resident team, you literally could go back to your team room after you resident round, put in the additional things, like, for example, the assessment, the plan, sign your note, and you're done. The quicker you learn how to document in medicine and capture what's going on of critical issues, the faster and more successful you're going to be as a physician. The major driver of burnout with physicians is physician documentation. Now, AI hopes to pass into that kind of world and decrease that, but that is yet to really be determined. Even the largest papers from Kaiser, for example, in California, still show that the minimization or the reduction of total time for notes is only a couple minutes per note. So again, learn how to quickly capture what's going on. This will be one of the major things that'll help you not only in your rotation, but your clinical practice, if you're in surgery or not in your eventual career. Look at the roadmap. Remember, listen more than you talk. Remember, watch those who are speaking. Listen to the language that attendings are talking to each other, and listen to how the residents are talking to each other and talking to you and talking to patients. So you're learning a vernacular, not only what is in surgical practice, but how we speak to the lay public to convey certain things to them about surgical disease. Spend time with your patients. You're one of the only team members that can spend a significant amount of time with patients in the midst of an individual day. And remember, it takes trial and error. You're going to mess things up. That's part of being in the environment. Give yourself permission to mess things up. Okay. That's the major thing I find with medical students is they don't want to kind of get into it. You've got to kind of embed yourself into the environment and to really learn and to thrive in surgery. Take time with your friendly AI. I always put this here too, is that, present to your AI. So you might even be driving in the morning and say, I want to present this patient to you like I'm presenting around. So let AI give you some feedback. It is incredibly beneficial. And I found a lot of medical students really get a lot out of this. So you can talk to all the major models. They all have a mobile version that you can put on your phone while you're driving in or on a bike or walking into the hospital. It's going to be pretty helpful to you. Also, think through what you're saying. Listen to, again, the language of each specialty. How does cardiology talk about cardiac problems versus CT surgery? Listen to how doctors speak. Get involved in the process. Help the resident and the attending, but ultimately try to help the patient. Remember, your education is your education. You have the right to advocate for the best education you can get, but you have to be an active partner in it. And you have to remember that you are got to continue to educate yourself while caring for your patients. The clerkships will require you to work with and for patients. It's just that simple. You have to do that to be in the environment. And so my advice to you is be active learner, and then think about how other specialties talk to each other and work on your patients and work with your patients and for your patients. And then remember, a lot of times I think one of the most valuable things is if the consult resident goes to see a consult and there's nothing going on, go with them and help them and say, hey, how can I help you with this consult? You'd be surprised what you learn when you actually see disease present to you in real time and what you remember. So back to this kind of rotation here, right? So I showed you this is kind of the structure of our. So remember for us, and I tell students this all the time, usually subspecialty or specialty rotations or exposure to surgery, that's a great time to read for the shelf and study for your shelf exam. And then during your core rotation is a good time that you're in the midst of working in surgery. So therefore you should be reading for the patient and for the case. And try to get along. Remember, you're part of the team. You're trying to help your patients. You're trying to align with powerful leaders within the clinical environment. Spend time with those attendings and those residents and in individual clinical situations, especially for consults, for example, as I mentioned previously. See what they do and don't do, and watch where you can see mistakes where an attending might miss something, and maybe you caught that, and you might have should have advocated for that patient and for you in the midst of that. The operating room, I always put this in here. Try to go to as many operations as you can. This is probably the only time in your whole life, if you decide not to be a surgeon, that you will be in the operating room. This is the most exposure you'll have to the operating room. See it, remember it, read about it, and tell it. Speak out the language to your fellow students. You think you're just standing around a table holding a retractor, but a lot of times you're absorbing knowledge and you can pick up a lot of things. This is where a lot of connections are made with medical students. They learn how nurses interface in the operating room, how anesthesia works. You get exposed to other specialties, but you want to be seen as a surgical student. You want to be introduced. You want to introduce yourself to the team as a surgery student, and you want to increase your visibility. And it's blood, guts, and gore. So not everybody can handle the operation or the sight of blood. That's okay. Let your resident know so they can adjust your schedule. Okay, we want you to be exposed to surgery, but we want you to have exposure safely. Okay, I've seen lots of medical students pass out in the midst of operations. I do not want that to happen to you, so be aware of that. Scut work, I always put this in because students always ask me. So it's trivial, tedious, dirty, lab draws, unrewarding, disagreeable, transport. These are all kinds of things you hear about scut work. So remember, scut work, should I do it? I get asked that a lot. Remember, you are part of the team. Now, that means you're kind of a cog in the wheel of the major machine in medicine. To do is to understand and is embodied learning. So yeah, maybe you take the patient down for a chest x-ray, and you guess what? You take something with you and you read while you go down there. So you get the x-ray down there, and then you see how the x-ray is done. Then while the x-ray is done and you're putting the patient into the wheelchair, you might go find the or the radiologist and say, hey, can you help me just read this x-ray right quick? You might be surprised how much knowledge you get just from being present for when care is being rendered. So, but the more you can collect information about the environment and about the patient, how they go through the clinical environment, the more powerful you become as a team member. So it's something to keep in mind. I'm not saying that, and then there's always extremes to this. I'm not saying that all of those things previously is something you should be doing, but you got to figure out exactly how you can help and not necessarily be used as free labor. And I think there's extremes on all of that. So my suggestions are always round early, fast, hard, rinse, repeat. Hard, fast, rinse, repeat over and over and over again. Be honest, work hard, and spend time with your patients and listen to them and have fun. This is the only time that some people will ever do surgery. And it's interesting when I run into medical students I've had previously that are from other specialties, they always remind me of that I've always told them that and said, I really enjoyed a rotation surgery with you. I just decided that it was not for me in my career, but I appreciate the exposure that you gave me to the specialty. My parting words are talk to each other, talk to those outside of medicine, talk to your clerkships, have fun. And it's a unique time in your life and you try to enjoy it. The ultimate lesson, again, is you're becoming a doctor. So what does that mean? That you try to do what's right for your patient, but you need to educate yourself because eventually you'll be taking care of other patients and your education is crucial in the care of those patients. But keep the patient in the center of everything that you do. So this is a tool then, and this is the QR code if you have any interest. And you can always email me at michael@vascularsurgeryexpert.com. I'm happy to send this to you. So this is called Vulcan, which is vocational understanding of lifestyle, career, aptitude, and navigator. It's 12 questions that help you understand and discern maybe your potential desire to be a surgeon. It's based on the 25 years of peer review literature that I pulled together to develop this kind of AI tool. And the most important thing is that it's free. This is the QR code for it here. And then also, if you want to join me online, developing and pulling together a great community of online students, residents, and trying to pull together people who have similar and like-minded thoughts in terms of medical education. And this is for medical students and surgery, those who want to match into surgery, those who want to match into vascular surgery, general surgery residents. And again, this is free. This is my website. You can sign up for any kind of notifications from me there. And I'm happy to interface with you. And then finally, this again is my email, michael@vascularsurgeryexpert.com. Here's my cell phone. You feel free to text me at any time. My LinkedIn, and then my website, vascularsurgeryexpert.com. And I think with that, I can stop sharing. And I'm happy to take any questions. There we go. If you want to just raise your hand, I can unmute you and let you come into the webinar if you guys have any questions. And if not, that's fine too. It's really to you. Okay, very insightful. Thank you. You're welcome, Miss or student Dr. White. And if you guys want to be unmuted and ask a question directly, I'm happy to do that. I can unmute you and let you turn on your camera. It's up to you. And I'll just give you guys a second to process some of that. Go Rams. Yes, there are lots of VCU students that are on. I am from VCU. I was educated at VCU. I went to medical school at VCU. I'm full professor of surgery there. But I work at the VA. But yeah, go Rams. We're the 11th oldest medical school in the United States. And I don't know if I can say this last name correctly. Gargani. So student Dr. Gargani. Thank you for attending. We'd love to have you. Please interface with us. We're happy to help you any way we can. Oh, just as an advertisement, we have another webinar coming up next month. And I can probably share that. Let me see if I can pull that up. Let me see if I can pull this up right quick. That's okay. Let's pull this up right quick. These are our next set of, everybody can see that. There's Sting in the background. He was here in Richmond. I heard him play. This is July 15th. The next one is actually 30 days from now. And this is going to be posters to podiums, building an academic portfolio. Here's the QR code. You will get an invite to that shortly after this meeting. And then M4 students maximizing National Vascular Surgery meeting experience. And that'll be in September. That kind of dovetails for those of you on the East Coast that want to go to the Eastern Vascular, which is in DC this year. All right. Yes, and one of the questions was, is it possible to have access to these slides? Yes, I will send you actually a recording to this, and it should have a link to the slides. You guys should be able to get to those. All right. Well, I look forward to everyone interfacing with you. Thanks again for taking your time. Please spread the word. If anybody else would like to attend this, I can always send the link to the slides. And I hope that you're having a good year. It's the beginning of the academic year. It's in July. As I mentioned, sometimes people think that there's higher mortality rates in hospitals, but in reality, that's not been shown to be true in a large study. So there's no such thing as the July effect. So, all right. So with that, I'm going to end the webinar. Thank you again. Please feel free to reach out to me if you have any questions or concerns. I'm happy to interface with you and continue to interface with you. I'll just put this contact information up. If you have any additional questions, I'll leave this open for a little bit. And then I will be ending the webinar in about another minute. Thank you again for your time, and you guys keep working hard. And you have one of the hardest jobs in the United States is being a medical student. Have a good night.